collection of cases of refractory rickets, whom he will present it. And then we will have another compilation, which will largely be working in terms of the disorders in the form of hypoparathyroidism and pseudohypoparathyroidism and other aspects which will be there. So we will start off basically with the first part with Dr. Subrato's talk. No, we'll do it after this. And we'll do after. Achha, achha, theek, theek. Yes, yes, that's good. So, yeah. So Dr. Subrato will talk about the refractory rickets part in terms of evaluation, management, and the challenging cases. How do we handle out in that perspective? So over to you, Dr. Subrato.
Okay. Thank you. When I was looking at the audience, I'm really amazed by the resilience and the tenacity. But when I look at Anurag, who stood 11 hours yesterday with, his PG student from time to time, I think, we need to increase our resilience more. So without a break, without further ado, I'm going to plunge into this management of resistant rickets. I'm going to start with a little bit of, very little bit of physiology, and which I guess most of you know. So I'll gloss over those very quickly so that we can save time. Now, everyone is aware that rickets is a disease of growing bones in children due to inadequate mineralization. Osteomalacia is due to inadequate mineralization of bone, osteoid in adults or children, in children whose epiphyses have fused. And osteoporosis is actually reduced bone mineral density and increased osteoid. So actually, it is the osteoid which is weak, and the amount of mineral which should be fortifying the osteoid is less. So this is the bone endocrine axis, which envelops the gland, the parathyroid gland, the skin, the liver, the kidney, and the bone. Now, the most important role of vitamin D is to keep calcium between 9 and 10 milligram per deciliter. And this does with a variety of activities like increasing absorption of calcium, incidentally phosphorus as well, leaching out bone from the, leaching out calcium from the bone, increasing reabsorption of calcium from the kidney, and also bone mineralization. These are some of the roles of vitamin D. Now, one of the areas of controversy, and this is because I've been following the guidelines of what is vitamin D level, what is normal. And I was still sitting, in Boston 2011, when Hollick, who is a great proponent of vitamin D, although he's sitting in, in a non-tropical country, but he had the most publications, and there he declared that sufficiency will be more than 30 or more, and deficiency less than 20. And if you look at all the guidelines in all the blood reports which talk about vitamin D, they still have more than 30. And so the world still continues to listen to the US of A. But in reality, there have been many more, modifications, and we'll talk about that. The global consensus recommendation on prevention and management of nutritional rickets, that came up in 2016. And we have actually interacted very closely with some of the players like Craig Munns, who's come multiple times to India, including the 2019, ISPE at Kolkata. I don't know how many of you were there. And his comments, both on stage as well as informally, is 20 nanogram per ml and above is sufficient for bone. He's very categoric and based on meta-analysis. And there were a lot of, some of our people as well, Anju, Rajesh, and Vijayalakshmi Bhatia, who were there, who also added to their, experience. But this is important to understand that 20 nanogram per ml or more is good for skeletal, for skeletal strength, and not 30. And between 20 to 30 is apparently for extraskeletal. So this is the global consensus. Sufficiency is 20 nanogram per ml. Insufficiency is 12 to 20 nanogram per ml. And a lot of you, I'm sure, are aware that there is this difference between nanomole per liter and nanogram per ml. And oftentimes it's so important to pay attention to what the unit is, because Dr. Lalpath gives in nanomole per liter, and rest of the world, including ThyroCare and such others, give nanogram per ml. And the way to convert is to divide nanomole per liter by 2.5, and you'll get nanogram per ml. So, the treatment in the Indian Endocrine Society was 50,000 units. We have 60K, they have 50K for 6 weeks to achieve blood level of 25 of greater than 30 nanogram per ml, followed by maintenance therapy of 400 to 1,000 IU. And 1 to 18 years, you could also give daily 2,000 per day for at least 6 weeks, or 50,000 weekly for 6 weeks. But the global consensus says that the treatment of vitamin D deficiency rickets is 2,000 IU per day for minimum 3 months, oral calcium 500 milligram per day as dietary intake or supplement regardless of age or weight, and recommend oral treatment over parenteral. And this takes us back to those days when I was in CMC Vellore in 1984. If there was rickets, which was unmasked after the malnutrition got better, we used to give them STOS therapy. The reality was there was no way we could predict if there would be follow-up. And even today, that is, despite all these guidelines, if you have a patient and you feel he will not come back, especially in a setup where it is iffy, they have come good, they may not come back, I think give a shot. 3 lakhs below 3 years, 6 lakhs above that, at least give a shot. But don't be like the orthopods who believe 6 lakhs weekly for 6 weeks is the treatment of nutritional rickets. And for them, all rickets is nutritional, and they don't believe there is an entity called resistant rickets. I hope there's some orthopods here. We can have a healthy debate. So as you know, the maximum amount of vitamin D comes from the skin, and 290 to 315 nanometers, and the timing is between 10 a.m. to 4 p.m. and it goes through this entire rigmarole, and from the skin, pre-D3, D3, 25 hydroxy vitamin D3 to calcitriol. And this is the pathway so when it was stated vitamin D deficiency does not exist in India, and that was in 1973, sun everywhere, but not a drop of vitamin D. And the reason for that is our skin, complexion. We have a stage 5 in the Fredrickson classification, which essentially prevents us from absorbing the vitamin D. And of course, we are all sedentary and we are not available between 10 a.m. and 4 p.m. to bask in the sun. So what is rickets? It's a disease of the growing child, impaired mineralization of the growth plate and osteoid, and there's low serum phosphate is fundamental to the pathogenesis of rickets. Interesting. It's not the low calcium, it's the low phosphate, because it is the phosphate which causes apoptosis or hypertrophic chondrocytes caused by phosphate ions. And when there's hypophosphatemia due to any reason, then the growth plate becomes rachitic. So these are the radiology cupping, fraying, splaying, and these are the sine qua non of the radiologic features. Now, this is a slide which I borrowed from Anurag, and it says calcopenic, phosphopenic, and in between you have distal RTA and proximal RTA. And as we go through, we'll go more about this. And this is another slide which I had borrowed from an earlier presentation of his, and I just will leave it on for all of you to just look at it. It's very, very self-explanatory. These are the mechanisms, and this is actually elaborating further the way that vitamin D is produced, and defects at different levels can cause different manifestations. Now, when to look for resistant rickets? No therapeutic response to vitamin D or calcium. Features of refractory rickets present, which may be polyuria, hypokalemia, nephrocalcinosis, NML hypoplasia, failure to thrive, pathologic fractures. You may see alopecia, seizures, and refractory hypocalcemia. You may see relative sparing of upper limbs and chest, and lack of hypotonia and dense bones. So how do you diagnose? These are some of the descriptions, and you may take a picture of this because this is typically what we do: calcium, phosphorus, alkaline phosphatase. Never just do a calcium alone, which all of you are aware. Do a creatinine, because renal failure is quite up there in causing metabolic bone disease. Look at the albumin, so you can do a corrected serum calcium. Vitamin D is important. I try to lump PTH with it. 125 is only if necessary. When do you do a venous blood gas? Failure to thrive, short kid, breathing a little fast, and you do a VBG, and there you go. You have renal tubular acidosis, don't have to look further. And I have diagnosed several of these cases. Just if you see short stature, failure to thrive, rickets, and we'll talk about it as we go along. So let's talk about the 7-month-old baby, failure to thrive, short with hypotonia. And basically the baby was referred to me because he was not growing. Now, for a lot of pediatricians, not growing means not gaining weight, because nobody measures the length anyways. So he was not growing. Why? The weight was 6, 6.1, 6.2. And in reality, I guess that case is not here, or maybe come back later. But that baby was perfectly well-looking, well-nourished, short kid. Did an X-ray of the left hand and wrist, and there was rickets, and we treated the child. Was nutritional rickets, and did very well. Now look at this child: failure to thrive, and weight, height, both compromised, low calcium, low phosphorus, normal serum creatinine. So this child had actually received oral vitamin 3. So despite all these recommendations about oral better than parenteral, and was given calcium supplements, but after the 2 months, the LP went higher, calcium went lower, the PTH rose, and the pediatrician freaked out and was worried about resistant rickets and started calcitriol. And this is how, the X-ray looked. But took a history. This child was having chronic diarrhea, and basically gave STOS therapy and some oral calcium, and things resolved. And later on, we found the TTGA was strongly positive, and this was a case of celiac disease. So nutritional rickets, malabsorption induced, you need to give STOS therapy, and they heal. So this is not resistant rickets. Now, this is a 7-year-old girl presented with bowed legs, treated with multiple doses of vitamin D, 6 lakhs, 3 lakhs by orthopods, investigated in a tertiary center in Kolkata in the government sector. No diagnosis was made. On examination, mild rachitic rosary, widened ankles, and there was genu varum, which means bowed legs. In fact, the most important thing is varum, which means bowed legs. And this was the chemistry: calcium low, ALP raised, phosphate low, creatinine normal, and 25-hydroxyvitamin D was fine, and PTH was also normal. So what's going on? Low calcium, high alkaline phosphatase, and low phosphate. So whatever. So what we did the urine calcium creatinine urine calcium phosphate ratio, and we found there was a loss of phosphorus, and that was TRP was less than 80%, and this was X-linked hypophosphatemic rickets, and was managed with phosphorus, with calcitriol, and underwent the surgery, and look at how this child became after doing the osteotomy. She's now lost to follow-up. So the standard care is elemental phosphorus, vitamin calcitriol, watch for nephrocalcinosis, and you must do serial measurements of KUB from time to time. So every 6 months to a year, to see that you are not causing nephrocalcinosis. Case 3, presented with genu valgum, short, underweight, was given vitamin D, was given transfusion because the patient was anemic. And guess what? The urea was 160, creatinine 5.7, PTH was raised, vitamin D was not that low, and this was refractory rickets, renal. Case 4, 3 years old, severe failure to thrive, polyuric polydipsic, low calcium, low phosphorus, kidney function normal, low potassium. What's the diagnosis? Anyone? Low phosphorus, low potassium, alkaline phosphatase raised. Tubular absorption, urinary tubular reabsorption of phosphate, less than 80%. So this is a Fanconi syndrome. So how, and we looked further and looked at the looked at the cornea, and there was cystinosis, and worked this up, anion gap acidosis, and the treatment is cystogene. Very expensive. I have a Bangladeshi little girl who's getting this. Now, this is the case I talked about, 1 year, 2 month old girl who's failing to thrive. There's nephrocalcinosis, low calcium, low phosphorus, and low potassium with increased PTH because of, by the way, how do you differentiate between primary and secondary hyperparathyroidism? Is the calcium. It's the calcium. In primary hyperparathyroid, calcium is high. In secondary, it's low to normal. It's a very important point going forward. So this was secondary to tyrosinemia. And so this was an actual proximal RTA, because you see the furosemide challenge test, the urine pH is less than 5.5. And these are the calculations we do for TMP GFR and fractional excretion of phosphate. And anything less than 80%, you're worried. And this is how you approach suspected RTA. Urine net charge. If it's negative, it's diarrhea. If it's positive, then it's an RTA. And look at the urine pH with the use of a pH meter. And if it is more than 5.5, then the chances are that you're dealing with a distal RTA. So the management of distal RTA is bicarb, potassium, control of hypercalciuria. And proximal RTA is bicarb, potassium, phosphate, vitamin D, and calcium. And renal failure is bicarbonate and management of renal failure. Case 6, prolonged history And treatment for rickets, multiple courses of vitamin D, delayed dentition, motor development. And this was the biochemistry. And why do I say VDRR type 1? How will you diagnose VDRR type 1? What happens to the 125 dihydroxycholecalciferol? Is it low? Absolutely, it's low. So look at this kid now. This is a very important picture to take home if I'm obstructing. This is one of the very, see, look at this, ravaged with deformities. Look at the legs. And in fact, they have calcium problems as well. And there's a cohort in Israel. And I was talking to many years ago to some of my Israeli colleagues like Zeev Hochberg. And apparently some of these, the Jewish population is ingrown, Ashkenazi Jews, consanguinity, etc., etc. They have a lot of these disorders. And some of them were on Hickman's, receiving IV calcium from age 8 months of age, because the hypocalcium was so refractory, they would seize. And these patients were VDRR type 2, they have alopecia, and they have, unfortunately, a receptor problem. And despite very high amounts of 125, they are still calcopenic rickets. So this is a little summary. In vitamin D deficiency, phosphorus is low. You know why? Because of raised PTH. And why is the PTH high? Because the calcium is low. So, and why is the calcium low? Because the vitamin D is low. So that is deficiency. In type 1, the most important problem is that the PTH is high, the calcium is low, and hence the phosphorus is also low because of the effect of PTH. ALP is raised, but 125 is low, whereas in VDRR type 2, another calcopenic rickets, it is very high, 125, because of the receptor problem. In hypophosphatemic rickets, the primary problem is low phosphorus, hence the alkaline phosphatase is raised. The PTH is normal, 25-hydroxy is normal, and the treatment is basically phosphorus supplementation with activated vitamin D. The nephrology, for some reason, do not give activated vitamin D3, and the particular marker of efficacy of treatment is the alkaline phosphatase. So management, renal failure is calcium and 125. Distal RTA is alkali with, if there is rickets, then you give phosphorus. Proximal artery is alkali and phosphate. And hypophosphatemic rickets is phosphate and activated vitamin D. And so is VDRR. In type 1, you give low dose 125. In type 2, you give very high doses, still with very little impact. So these are some of the medications which you use. And it is good to take a picture of this because we keep juggling with all these medications. So I made a list so I don't make mistakes. Summary messages: look for vitamin D response. Ensure vitamin D is more than 30 nanogram per ml DL. Avoid repeated vitamin D doses. Look for features of resistant rickets. Early evaluation necessary. Investigate systematically and treat appropriately. So not all bowing is rickets. This is what? Blount's disease. And it needs surgical repair. So thank you for your kind attention.
Thanks a lot to Subrata for the wonderful timed presentation. And yes, so we are going a bit behind. We are only around 15-20 minutes behind. We hope to finish by 1:15. The entire session should be over. So I don't think it'll be a problem. So maybe we will now start with the grand round, and if you see any questions come up from there. So please. So the next session is basically going to be interesting cases that we are going to see with regards to the calcium and other bone disorders. And for this, we have got a panel who will be coming up and discussing about these interesting and intriguing cases. So I like to request Dr. Chetan Dave, who is a pediatric endocrinologist in Rajkot. Dr. Chetan. No, they have changed. And we have got Dr. Vijay Jaiswal. Dr. Vijay. So I think we start off with Dr. Subrato and Dr. Sugandha. Dr. Sugandha, she's there. So I think two of you are here. I think they will join soon. So they didn't expect Dada to finish off so quickly. They were thinking of longer duration, I think.
You know, I put on the Shatabdi or the Rajdhani Express because we were running late.
Yeah.
I would have liked to dwell on some of these things, but I feel that this has been gone over and over again. It's important to show the visuals and some messages.
It was very wonderfully put. So Dr. Vijay, please come up. So now we'll start off with this session, and we will be largely talking about, and we'll try to see how much we can cover. We're going to talk about impaired PTH effect in the form of hypoparathyroidism, pseudohypoparathyroidism, increased PTH effect in the form of hyperparathyroidism, and finally about low bone mass. So we'll start off with impaired PTH effect. So when we say impaired PTH effect, we mean it could be a PTH deficiency or a PTH resistance. Now, PTH deficiency in the younger age group will largely be genetic. And one condition you should always be aware about will be DiGeorge syndrome, which will be associated with cardiac malformation. So early onset within a week, severe hypocalcemia, cardiac manifestations, think of DiGeorge syndrome as a possibility. Acquired and syndromic, of course, as we discussed, you can also have abnormalities in the hearing, severe short stature, and renal failure. So whenever you have hypoparathyroidism, look for deafness, look for renal anomalies. Older age group, it's usually autoimmune. And when I say autoimmune, it is APS1 unless proved otherwise. So if you have hypoparathyroidism, be very, very cautious about the other manifestations of APS1, including adrenal insufficiency. And if you have a child with APS1 who has developed hypercalcemia and whose calcium requirements come down, think of a possibility of a cortisol deficiency, which is evolving. Now, rarely you can have a defect in the sensing. And when you have a sensing defect, you will have, body will think your calcium is too high. So you will have hypocalcemia with hypercalciuria. So calcium excretion becomes a very, very important tool. And finally, you can have resistance because of a PTH problem or largely because of pseudohypoparathyroidism. You will have hypocalcemia, hyperphosphatemia, a short child, plump child, brachymetacarpia, cataract calcification. So I'm just making an overview before we go ahead on the cases on that. So when should we suspect of an impaired PTH effect? If you have hypocalcemia with hyperphosphatemia. Everybody whose calcium is low should have a low phosphorus because your PTH goes up. If your phosphorus is high, you're dealing with a form of a PTH problem. Other than that, you have to exclude renal failure, of course, as a possibility. Magnesium deficiency will also induce PTH deficiency and resistance. And finally, prolonged vitamin D deficiency will cause a PTH resistance like state. So hypocalcemia, hyperphosphatemia, normal creatinine, normal vitamin D, normal magnesium. That's your impaired PTH effect. It's a rare disorder needing lifelong treatment. So don't overdiagnose. If you have coarse skin, brittle hair, intracranial calcification, cataract, and bone mass, you can think about these conditions. So you have to be careful. Very importantly, if your calcium is low, PTH should be sky high. So a normal PTH with a low calcium is significant. So you expect that if your calcium is low, your PTH should be high. If your PTH is not high, you are basically dealing with hypoparathyroidism, even if it is in the normal range. That's an important message. And of course, the approach will be once you have done a phosphorus, which is normal, creatinine, which is normal, you will then go and look at the PTH. If the PTH is low, of course, you're dealing with basically a hypoparathyroidism. Now, whether you have a calcium sensing receptor effect, you will decide based upon urinary calcium. And if PTH is high, exclude vitamin D deficiency and then think about PHP as a possibility. And these are the rarer causes to look at from that perspective. Management is basically you have to treat calcium and you have to give calcitriol. This has been the conventional treatment for both hypo as well as pseudo-hypo. Now there are roles which may happen with regards to the role of PTH. Some people have used PTH to provide lesser risk of hypercalciuria, which may happen in that regards. Hypoparathyroidism, you may lose a lot of urinary calcium causing nephrocalcinosis. So your targets are basically lower from that perspective, while in pseudohypoparathyroidism, your targets are generally higher. And this is something to remember, because pseudohypoparathyroidism does not cause nephrocalcinosis. Your calcium targets are higher in terms of PHP, where you will keep it around 10, while for hypoparathyroidism, your targets will be somewhere around 8.5 to 9. And calcium sensing receptor will be exquisitively sensitive to develop hypercalciuria. So you will use much lower targets of calcium from that regard. So within this background, we'll now push the cases to our experts and get the opinion on that. Vibha.
Thank you, sir. Moving towards the first case, we have this 4-year-old girl who presented with kidney and muscle spasms. Her ionic calcium was 3.1, which was low, and a high phosphorus level of 8.4. And she had a high PTH level of 130 picomole per liter. So, is this PHP, sir? Dr. Vijay, do you agree with this diagnosis?
Actually, I need much more information, just not only ionic calcium and phosphorus. So Dr. Anurag sir has already told you that how to approach. So before just jumping on the diagnosis of PHP, I would like to see that how renal function is there.
So I think that's a very valid point. So now what are the results, Vibha?
Definitely, sir. Her creatinine was high. It was 2.4 milligram per DL.
Okay. So this, you can see that this is renal failures. So with high phosphorus, hypocalcemia. So before jumping to the diagnosis of pseudohypoparathyroidism, it is always important to look for these renal parameters. And you can see in this case that high create. So pseudohypoparathyroidism should be second to renal.
And always, this is a rare disorder. So don't
Yes.
jump into condition, exclude a creatinine, magnesium, and vitamin D. This is what.
And also any hypoparathyroidism,
Yes.
meaning not necessarily just pseudohypoparathyroidism, any hypoparathyroidism. Because one of the things is, as endocrinologists, after some time, only thinking of parathyroid, you're thinking of all these, endocrine diagnosis. But remember, in this constellation of high phosphorus, low calcium, the first and the commonest is renal failure, unless proven otherwise.
Yes. Very important point.
Thank you,
Next
sir.
case, Vibha.
We have this 3-month-old girl who was referred to us for seizures. Her ionic calcium was low, and she had a phosphate level which was also low. And when we did the PTH level, it came out to be low. So, Dr. Chetan, what do you think? Is it hypoparathyroidism, or we should work up again?
As we know that deficiency of parathyroid hormone will lead to low calcium, but as it is also causing phosphaturia, if there is hypoparathyroidism, phosphorus shouldn't be this much of low. This low phosphorus suggestive of normal or increased parathyroid action rather than hypoparathyroidism. And first and foremost, if the phosphorus is low, we should be looking towards vitamin D causes rather than jumping into direct PTH level. So maybe I would like to go for first vitamin D level.
Definitely, sir. When we did the vitamin D level, it was low.
So now, Chetan, why do you think this PTH was 3.4? And this is a very, very common problem we see.
Yes, because PTH is a labile hormone. It should be done from the plasma, and it should be stored or transferred frozen. So many of the labs are outreach and with the distance to the hospitals, they are not doing PTH. So faulty transport or maybe a delay in the processing of the sample might be the reason for low PTH.
So I think this is the big message, that if your phosphorus is low, why is the phosphorus low with the PTH being low? It's not fitting into the picture. So you always have to look at the PTH as a thermolabile hormone and transport PTH in eye. This is what we discuss as a pre-analytical problem in terms of your assay.
And in this context, I must say, for all budding physicians, pediatricians, pediatric endocrinologists, if something doesn't fit the clinical scenario, don't blame the patient, blame the lab. In fact, very recently, I was getting a spate of TSH 1.8, 1.9, FT4, 0.4, where the upper limit of normal, lower limit of normal of 0.9. So Apollo was creating in Kolkata, hypothalamic hypothyroidism, and the parents were all, bent out of shape. So whenever that happens, check from another lab, no matter how well respected your lab may be.
Thank you so much, sir. Moving towards the next case, we have this 7-year-old girl who presented with kidney. She had a low calcium level and a high phosphorus level. Her creatinine level was normal. And when we did the PTH, it came out to be within normal limit. So Dr. Sugandha, how should we approach this case?
So now this is again strange, Dr. Sugandha. The PTH is normal and yet the phosphorus is high. What do you think is happening here? And we have excluded renal failure.
So first we see that there is hypocalcemia and phosphate levels are high. So whenever we see phosphorus levels, we should think about creatinine. Then we see that the creatinine is normal here. So the next step should be an assessment of PTH. But for that level of hypocalcemia, this PTH, although it is within the normal range, is abnormally normal.
Yes.
So basically the PTH should have gone up. And it is, despite that level, we suspect that this is low only,
Yes.
despite the fact that it is in range. So PTH is low for this level of calcium.
I think that's a very, very important point. Often people say, what is the normal range of PTH? I would say there is no normal range. You look at what your calcium is. You correlate PTH with calcium. You correlate insulin with your glucose level. You correlate your ACTH with cortisol. So always do, as Dr. Subrata was saying, this is the post-analytical issue in which it's us who are making a mistake. So a normal PTH, as I said, with a low calcium is low. That's the end of the story. If your TSH is less than 20 and FT4 is low, think of central hypothyroidism. So it's a contextual assessment which becomes important, I think, in this case.
Thank you, sir. We have this 1-week boy and we got a reference from the NICU for his seizures. His NI level was, NI calcium was 2.4 only, and he had a high phosphate level. His creatinine level was within normal limit and his PTH was again low. So Dr. Subrata, sir, how should we approach this case and how should we manage this case?
So have you noticed that in that stem, how importantly creatinine is displayed? So the serum creatinine is normal. Now I'll put on my endocrine hat. So a PTH of 2 is low in the face of a calcium of ionized calcium of 2.4, where the normal is some 4 to 5.65. Yeah. So essentially, this is hypoparathyroidism. Now, the next question as a clinician is, are there any other features? Because, in this age group, if you look at hypocalcemia with low PTH, billions of them will come out. And DiGeorge's syndrome, Kearns syndrome, Kearns, all kinds of things.
So he had a cardiac abnormality, truncus.
So basically, this is the catch-22 or the DiGeorge syndrome, in which they have, thymic abnormality. They may have a conotruncal defect associated with this, and they may have none of these. I'm following 2 DiGeorge's syndrome. Later on, develop hypothyroidism, and that is what it is. But yes, in this context, the important learning lesson is that PTH is low. Think of congenital causes of hypoparathyroidism and yet DiGeorge's syndrome.
Because this is a contiguous gene deletion. So you may have all or some. It's like Turner syndrome. Which all genes are affected, you will have a manifestation. And one case which we saw had a severe immunodeficiency. Yes. So that has to be a very, very cautious scenario in that regard. So immune assessment becomes important.
We have our next case. We have this 3-year-old boy who presented with seizures. He had a low calcium level and high phosphorus level again, and with a normal creatinine level. On the examination, what we found, he has a whitish deposition over the tongue and the gums.
Which was never washed out with a lot of brushing and everything.
And he had a PTH level which was low. So Dr. Vijay, what do you think about this case?
Yes. Thank you. So again, so history taking an examination and correlation of all the things in one setting is really important. So we can see here that this is a 3-year-old boy presented with seizure. Of course, this was due to severe hypocalcemia. Along with that, what we can see that PTH is low, so hypoparathyroidism is akin. But there can be, so hypoparathyroidism is association with candidiasis, yes. So there is candidiasis. So this is APS type of, that is autoimmune polyglandular syndrome, where we are going to have autoimmune polyendocrinopathy, candidiasis, and can be skin manifestation also.
Yes.
Ectodermal dysplasia can be there. So this is.
So in hypoparathyroidism, as Dr. Subrata and Dr. Vijay said, if it is congenital early onset, think of renal, cardiac, hearing, all those things. Acquired, most it has to be APS1 unless proved otherwise. So you may or may not have mucocutaneous manifestations. It may happen that later on, hypoparathyroidism is the first endocrine manifestation. So this you have to be wary about. So as discussed, the associations include adrenal, which happens a bit later. You can have liver involvement, urticaria, and this becomes difficult to identify. So now we can do the antibodies to interferon, which can give you a diagnosis in this regards. NGS plus minus may have some confusion. So it's still the antibodies to interferon is the diagnostic one. Yes, doctor.
Where are they doing these antibodies?
We have gone a couple of them, especially with Quest.
And what is this antibody called?
And interferon antibodies.
Is it only specific to?
It's specific for.
parathyroid?
No, it's basically antibody for the interferon in the autoimmune. The problem here is the autoimmune regulator gene, in which you've got multiple antibodies formed, and the one which is found to be most specific is this one for the interferon. So it's not parathyroid specific. For parathyroid, there is a NAPTH antibody which is separate. But for this case, it is interferon for AIRE basically. So this is the best marker, the most highest diagnostic accuracy is with this antibody. So this will predict somebody with urticaria and fever, it may predict the disease. But if you have all these features, you may or may not do that. But that's a different thing altogether. NGS, supposedly because of the gene pattern, it may not pick up in some cases. So that's why even genetics, this is preferred.
On follow-up, what we have found that he developed abdominal pain along with polyuria. He had a high calcium level, so we have to taper the calcitrol dose, and finally we stopped. Then his calcium levels became normal. So, Dr. Vijay, what do you think? What has happened with this boy?
Again, so we have to keep in mind that this is not a single disorder, and this is constellation of symptoms, and the things can be evolving over a period of time. So at this juncture, I would like to say, see that whether there is any adrenal involvement or not. So that I would like to see the cortisol level. And before that, actually, we can see the electrolytes. What are the electrolytes level? And you can see, I can see here that sodium was a bit lower, and you can see cortisol level is low.
So this is very important. So if you have somebody who has hypoparathyroidism and the calcium requirements come down, a first possibility thing you can do cortisol. Anyway, annual cortisol is recommended anyway in these cases. Yeah.
So we followed him after 2 years, and he was on calcium of 30 milligram per kg and calcitriol with 30 nanogram per kg. He was maintaining a calcium level of 9.8. And when we did the urinary calcium creatinine ratio, it was 0.4 milligram per milligram. And the USD showed the nephrocalcinosis.
So Dr. Vijay, what do you think we should do?
We have to see the level of cortisol, and we have to reduce the calcium.
So I think that's a big message we should discuss, that the target level of calcium in hypoparathyroidism is lower, around 8 to 8.5, because they will leak this calcium because the PTH conservatory effect on the kidneys is not there. So even at a normal level, the calcium will go out. So in hypoparathyroidism, I want to maintain 8, 8.5. I'm happy with that. And that's very important from that regards, and add thiazide, which will also help out in this case. So I think we were very clear that anybody who has got childhood onset hypoparathyroidism, think of autoimmune cause, look for mucocutaneous candidiasis, hypercalcemia at the point of adrenal insufficiency, and the calcium target is low. That is an important message.
So in another case, we have this 10-year-old boy who presented with seizures. He had a low ionic calcium. On examination, we found he has cataract, he has subcutaneous calcification, and the MRI and the CT scan he brought, it showed intracranial calcifications. So Dr. Sugandha, what do you think what we are dealing with here?
So on presentation, we have a boy who has hypocalcemia, and all these pictures depict a sign like they have cataracts, calcinosis cutis, intracranial calcifications, brachymetacarpia. So all in all, this picture is suggestive of a pseudohypopara type 1A kind of a picture. And with the flowchart that has been discussed previously, we should always look at the vitamin D and creatinine levels. If the creatinine is normal, then we should do PTH levels. And so
you had a very high phosphorus,
very,
a normal creatinine, and very high PTH. So this is a garden variety PHP. You should not miss this. But there may be subtle cases. Now remember, PHP is usually a later presentation. In infants, you will see a lot of cases of hypocalcemia, high phosphorus and high PTH. That is not PHP. That is basically a vitamin D deficiency, which mass presents like this. But this is a classical presentation, milder disease, and they will present like that. Now, the other big question is what should be the calcium target, Dr. Sugandha, in this case?
So here we can target the calcium to be around 8.5 to not a very lower target.
We can keep it at a higher level. The reason is that your urinary calcium absorption by PTH at that point is a biallelic representation. What I'm trying to say, it is not affected in PHP because it's essentially a sort of an imprinting defect. So they will not develop hypercalciuria. The main problem there will be skeletal resorption. So they will develop skeletal disease with no risk of hypercalciuria. So you want to maintain calcium at a higher level in this scenario. I think that's a message which we want to give in this scenario. So they will have skeletal effects. So hypocalcemia with high phosphorus, round facies, brachymetacarpia, keep higher calcium targets in that regards. So now we'll move towards the increased PTH effect. And when we say increased PTH effect, we have usually hyperparathyroidism, which can really be isolated, can also occur with men associations and sporadic. But usually when we say hyperparathyroidism in the pediatric age group, we have the neonatal presentation of the severe form of hyperparathyroidism, which is because of a calcium sensing receptor defect, which is homozygous. If you have inheritance from both parents, you will have very severe defect. If you have inheritance from one parent, you will have a milder defect. And we'll talk about a very interesting case also in this, which can present. You can have a sensing defect, which causes familial benign hypercalcemia, in which body is sensing your calcium to be low. So blood calcium is high, urinary calcium is low. They will never develop nephrocalcinosis. It's a benign condition, no need for treatment. These are extremely rare, so it's mainly hyperparathyroidism. So in the neonate, if you have severe dehydration, polyuria, hypotonia, check calcium levels. So all sick neonates, calcium should all be checked. Childhood, they will present more with hypertension. Nephrocalcinosis will be a major presentation. You get a calcium and you will get metabolic bone disease. So again, you have hypercalcemia with hypophosphatemia. So high calcium, low phosphorus. This is how PTH problems will act. Very importantly, you have to exclude causes of secondary hyperparathyroidism, including renal failure, vitamin D, and very importantly, treated hypophosphatemic rickets can cause such sort of a confusion. It may even cause tertiary hyperparathyroidism. So you have to be considering that. So hypercalcemia, hypophosphatemia, normal creatinine, normal vitamin D is what you want to establish. Again, interpret if your calcium level is high, PTH should ideally be 0. That is very, very important. If your PTH is high, this is hyperparathyroidism. If your PTH is normal, you can think of a calcium sensing receptor defect. And if you look at in that perspective, if you have a PTH above 20 in the setting of hypercalcemia, this is hyperparathyroidism. Look at urinary calcium. If it's high, this is primary hyper. If it's less than that, you give a vitamin D level. If it's normal, it's calcium sensing receptor defect. In between, you give a trial and that will give you a response. So essentially, you have to look at the PTH and urinary calcium, which will give you the diagnosis in that perspective, in that regard, then you can assess. Of course, if you have adenoma, you go for a minimally invasive surgery. Men one go for subtotal resection. But this is what you may see is the neonatal form where you have to do a complete near total parathyroidectomy is what is recommended. And usually in children, the lesions are more multifocal. So single adenoma removal is not going to help out. So from that perspective, we'll start with the next case.
So we have this 12-day girl in the NICU, and she was, we called a reference for this irritability. She was very dehydrated, and she had a very high calcium level of 18 milligram per DL and a high PTH level of 300 picogram per ml. So Dr. Subrata, how should we approach in this case?
How much was the phosphorus?
Phosphorus is very low.
So basically, the most, can you get back to the first slide?
Yeah, this is there.
Okay. The most important thing here is the clinical manifestation. The child is severely dehydrated, sick, and is 12 days old with a high calcium. So when I was talking about my presentation on calcium disorders and rickets and all that, one question I said that PTH is little later on. Here, one very important history has to be taken is this baby getting excessive vitamin D? The commonest cause of hypercalcemia in a neonate is iatrogenic. So with the PTH, I would have liked to see what is the vitamin D. So in any case, I assume that the vitamin D was normal, and the PTH was high. So this is a problem. So this is a condition in which there is severe high, life-threatening hyperparathyroidism. So, I mean, we can go through that algorithm, but this immediately what it does, it basically, and you see the urine calcium creatinine ratio, 0.3 per mg per kg. What is that? Normal, low, or high?
It is low.
Huh?
It's not high for the level of calcium.
It is not high. Now, what is being implied is this is a form of familial hypocalciuric hypercalcemia, in which if you have the homozygous form, and then you have very high levels of PTH being formed as well. So, this is the area, Anurag, which is a little iffy, because there is a very clear-cut entity of familial hypocalciuric hypercalcemia, where in effect, the calcium level rises because it is not being excreted, regardless of what the PTH levels are.
Yes.
But if you look at it from the entity of genetics, the homozygous form is NSPT. I mean, severe, hyperparathyroidism, neonatal hyperparathyroidism. And the milder form is FHH. But the treatment is totally different, because in here, if you want to go to the next slide, please. The treatment is, this is very important. These babies, you have to hydrate them. I mean, they keep coming. It's an emergency. So double normal saline, and then what else do you give?
We give diuresis, we give saline. And then
Diuretics, yes. You give steroids so that don't get absorbed orally. You give pamidronate. And recently, cinacalcet. So cinacalcet I've used only in one patient, and clearly it is effective. There is no doubt about it in a certain dose. And oftentimes when patients cannot go for surgery because they can be on cinacalcet for years, for months. But the treatment of choice is to remove the parathyroids and leave a small little sliver behind.
So this is very important. The same dose effect happens with GCK. So if you have a single gene with GCK, you will have very mild diabetes and we are happy. But if you have both parents affected with GCK deficiency, the child will have severe neonatal diabetes. So it's basically the same dose effect here.
And what is interesting is in this, if the father is,
we'll come to the case. Next case is there. So neonatal presentation, there was a familial benign hyper. So check the calcium and phosphorus in the family. You will get the diagnosis also. And surgery is the mainstay.
So we have this 20-day-old boy who presented with irritability. He had mild dehydration with a high not very high level of calcium, that is only that is 14, and the PTH level of 120 picogram per ml. So as sir has discussed, that this is looking like a hyperparathyroidism, and the surgery was planned for it. So
But over the next 2-3 weeks,
Yes.
once we give the conservative measures, he improved. So what is happening? He is having milder calcium than the last case. PTH is not that high. So are we dealing with something else, Dr. Vijay, in this setting?
Yes. We have to see again the whole perspective that what are the various levels. Contrary to the previous case, what I can see here that calcium is a bit high. PTH is not so high as that
Yes.
was in 300. Urinary to calcium create ratio is less. So again, we can see that whether there is any family member who is going to be affected, and that is the dose dependent manner presentation can be there.
So father had a high calcium with low urinary calcium. Mother was normal.
Okay, so as we are anticipating that probably this is not a case to be much worried. Of course, we have to have good monitoring and other things, treatment, but definitely there should not be any surgery to be done. And this can be a transient phenomena which can go over a period of
So
time.
this is basically that the child has a sensing problem, but the mother actually, he will sense mother's normal calcium as low. And in that setting, he'll start producing more PTH, and this will then cause this hyperparathyroidism. A bit like when we discuss about GCK deficiency, that if the mother has GCK deficiency, baby is normal, he'll become macrosomic. Here, the mother is normal, but the baby has a problem. So he senses the levels at low. So for some time, this hyperparathyroidism will be there, but postnatally, he will adapt. So very importantly, when you have a neonatal severe hyperparathyroidism, start with conservative measures, but always get the parental calcium phosphorus done very importantly, and maybe genetic testing also now it's available. So you can get a clue in that regards. It's a self-resolving condition, comes from the father, and then he'll become like a familial benign hypercalcemia, which doesn't require any treatment, basically. This is a very important part to look at.
And in utero, actually, these develop that hyperplasia of the
Yes.
parathyroid gland,
Mm.
and it resolves with time.
Just like IDM, sort of, infant of
Exactly.
diabetic mother sort of a thing.
So we have this 8-year-old boy who presented with abdominal pain. He had a calcium level of 12.2 and the low phosphorus level, and with a PTH level of 60 picogram per ml. So for this high PTH, surgery was planned for him. So Dr. Chetan, would you agree with this surgery, or we should do another?
Again, the calcium is not that much high, which can cause much of the symptoms. But of course, with this calcium, PTH should be low, which is not there. So definitely this is a high PTH leading to hypercalcemia. But again, we have to rule out the same calcium sensing receptor defect versus hyperparathyroidism. So next part is whether we need to see the calcium excretion. So maybe fractional excretion or a urinary calcium creatine ratio should be looked for. So this calcium excretion is low as with the level of calcium, which is going against primary hyperparathyroidism. And so this comes to a diagnosis of calcium sensing receptor defect, which does not require surgery in general. So no surgical advice should be given. Maybe we can try Cinacalcet if calcium is causing much of the symptoms.
And giving surgery will not help because main problem is urinary retention of calcium, which will persist beyond surgery, and you will never have nephrocalcinosis because they are not losing calcium. Your main worry is that. So PTH is not very high, bones are not going to be affected much. There is no urinary calcium, you will have no nephrocalcinosis. So why do
No,
treatment?
but why is the PTH high? I mean, actually, PTH 60 is normal.
So there is a calcium sensing receptor issue. So the calcium suppression of PTH doesn't happen. That's why you will need higher calcium level to suppress this PTH.
But 12.2 is quite high. Yeah?
Yes, you can have, sometimes the levels may go up, especially if they are given thiazide diuretics. The moment I have seen a couple of adults, they get thiazide diuretic, the levels will shoot up. So you have to be very, very cautious in that scenario. When they become dehydrated, illness, you can have mildish hypercalcemia. So often they are picked up only on routine screen. It's like your yesterday's condition we discussed that everybody gets a fasting sugar, it's 110, 120, and then you think of GCK. Same here, routine evaluation 11, 12, something like that. Sometimes you will get this picture. And especially in somebody is on thiazide, this will be really exacerbated. So that will be a message to look at.
The PTH will rise.
PTH will be slightly high because it is not being sensed. The calcium is not being.
Calcium sensing part is okay.
Yes.
But the hypocalciuria.
Yes. So hypocalciuria is causing high calcium. Plus your PTH is also high to a certain extent. It is high to a certain extent. It's not that high. So that's why when you have a homozygous defect, the level goes very high. So there is a tendency for high PTH, but it is not very high as compared to a primary hyperpara. In that case, the PTH will be much, much higher.
But there in that severe neonatal,
Yes.
severe hyperparathyroidism, that PTH is exerting effects.
Even here, it is playing some role, but the major role is the urine. It's a milder role here, but it's mainly the urine which is causing the problem.
But those patients, they also develop dehydration and all. So
Yes. So once your calcium levels go beyond a level, you will see what is happening here is that you are shifting your urinary calcium excretion to one side. But if your calcium was, let's say 12, you will not excrete anything. It becomes 20, you will start excreting. Just like GCK deficiency, if your glucose becomes above a particular level, your insulin comes into the picture and the sugar becomes normal. So here, if you have so much hypercalcemia, you will have hypercalciuria.
So it will basically break through that.
Yes. So how much it will conserve basically. Beyond that level, it will start working more. So milder, no calcification, urinary calcium is low, magnesium is high. This is another message. In primary hyperparathyroidism, magnesium is low. Here, magnesium is high, no role of surgery. I think we can try to finish off this in quickly. I think then we can go forward further. This is about the low bone mass. We had a wonderful discussion yesterday. Hemchand talked about the assessment. So I've excluded the assessment part from here. So low bone mass, most commonly you will see would be osteogenesis imperfecta. And second will be steroid-induced osteoporosis. These are the two most important. And the third, of course, is immobilization, where we are often neglecting that. And that's a very, very serious thing. I'll focus about these two primarily. So as discussed by the expert recommendation, now we have recommendation that if your PMD is more than -2, but you have spinal compression fractures, which means that Z score is not relevant here, you need to consider treatment. If it is less than -2, only treat when you have a clinically significant fracture, which Hemchand described wonderfully yesterday. And less than -2.5 without fracture, if there is a risk factor, if somebody is on steroids, if somebody is on some drugs which can affect, and then you can consider treatment. So BMD Z score is guiding you, but it's not the main driving force to decide treatment. And less than -3 without fracture, again, you may consider. Now, treatment option, of course, is zoledronic acid, which is a bisphosphonate now easily available. It's the next generation. It has got a highly potent anti-resorptive agent. And you have to think of the dosing. Very importantly, the dosing varies, the frequency varies because the risk of hypocalcemia is there. So you have to be very cautious in that regard. Give as an infusion. You can give in 50 to 100 ml normal saline. Over 30 minutes, there would be fever, and that will be there for a day or two. Pamidronate, we are not using much now because it required multiple infusions. Zoledronic is a much easier one. Denosumab is also available, which may help in certain cases, but not for younger children. Teriparatide has not approved for children. So I think this is something which
causes osteosarcoma.
In rats.
No, but still that holds true for children as well.
So that's why it has not yet been approved in children.
And denosumab is still, biggest problem is causes hypercalcemia rebound.
Once you stop.
So there is not much use still in children.
Yes.
And still the indication is postmenopausal osteoporosis. Yes. But two things. One is zoledronate is an anti-osteoclastic thing. The osteoblastic, we are yet to find anything yet. And when that comes, that
will be something like sclerostin. A lot of work is going on sclerostin analogs. So this is the monoclonal antibodies which are going to increase the osteoblast activity. So this is as I always said, if you talk about options of filling a tank, you can either say, okay, I'll stop the leakage and let the tank fill, or I'll keep on adding more. So when you want to increase bone mass, either you create more bone or you stop resorption. If you allow the pool not to empty, it will become dirty. So the quality of bone that is there because of anti-resorptive agents is not very good. That's why you've got avascular necrosis. That's why you've got fractures, abnormal things, but that's the option available. So bone formation will always be better. But unfortunately, PTH, as you said, at the moment, definitely not indicated in children because of the risk. I am looking more in terms of sclerostin agonist. That will be something which will help out in terms of formation. So when to treat specifically for OI in infants, if you have a congenital fracture and deformity, 2 to 4 years with recurrent fractures, and 5 to 18 years, there are specific recommendations of 2 or more fractures per year, which is there. And then you adjust the dose based upon BMD. You don't want to over-treat, because if you over-treat, you will have like a adynamic sort of a bone. Bone is not going to be very good. So less than -2, your dose is 0.05. Between -2 to 0, it becomes lower, half dose. And once you reach more than 0, then you make it even less. So basically, you have to slight dose titration. These are newer recommendations which are coming up in that regards.
So we have this 4-week-old girl who mother complains that she cries a lot while handling, and she had a history of recurrent fractures. Her X-ray showed reduced bone density, as you can see on the X-ray film, but she had no similar history in the family. So, Dr. Subrata sir, what we are dealing with?
4-week-old girl. So this is
Yes,
a
sir.
baby.
Yes.
And already recurrent fractures. So basically it's a OI. Now in OI staging, 1 is the mildest and the commonest. 2 is lethal. 3 is progressive. 4 is without, 3 is with blue sclera. 4 is without sclera. And then, in that form, 7, 8 are lethal again. In between, take your pick. So this is
more like an antenatal fractures.
Yes.
So it will fit into OI3. And now there are multiple OIs now, because OI is actually a term of weak bones, basically. What is it? Your bones are imperfect. So now if you go by the list, they say 25 causes of OI. It's all genetic causes. So this was turned out to be OI3. That's besides the point, basically. But I think the treatment options we already discussed, that zoledronic acid is there. And those who are comfortable with bisphosphonate, pamidonate also are using that. There's no problem.
Actually, I am a pamidonate, sort of fan. I won't say guru, because even today, although a lot of centers and the gurus of osteoporosis keep saying you can use it in young babies. What is your experience? You're comfortable giving in young babies?
We have been fine with this. We use a lower dose as discussed, and then it's okay.
And you give it every 6 months.
Yes.
And the response is good.
Response is pretty good. It's
The only
equal.
biggest advantage is a one shot.
Yes.
It's an outpatient thing, and you don't need to admit them. So costs come down.
Handling becomes difficult in private sector, admitting, risk of fractures, like suppose putting IV. So it's a messy thing. One shot is much we prefer.
But you have to put an IV for the.
Yes, the single shot. There you have to keep them for 3 days, multiple handlings, and all those things are there.
Because I have, with the expense of 30 seconds, the biggest problem of dealing with OI is when they hold the baby like that. I must say, Hemchand, in Chennai orthopedics, this baby was held so much that they developed crunchy fractures. And since then, the mother, the Bengali, has come back and she wants conscious sedation, because I told her, if you knock out the kid, we can give. So that time the baby was only 18 months. Now he's 6.5 years and they still want conscious sedation. So anyway, but that's the important thing.
So now on follow-up, what happened, Vibha, here?
On follow-up, we were giving zoledronic acid 0.025 milligram per kg, and the fever was well managed with the paracetamol, but the child developed seizures. So, Dr. Vijay, why does it happen?
So again, we have discussed, Dr. Anurag sir has already discussed that what is the property of the zoledronic acid. So again, there are some acute side effects and other things. Apart from that, we have to really take care of calcium, because it is going to produce hypocalcemia. And I think that this is the case where we are dealing with. So seizure due to hypocalcemia, and you can see the low level of calcium. So it means that we have to de-escalate so titration method of zoledronic acid should be again.
And always give calcium and vitamin D along with that. That is important to consider as well. Yeah. So now follow-up.
So after follow-up of 12 years, there was a functional improvement, and the fracture rate has also reduced, and she had a BMD score of -1.6 Z score. So, sir, how should we proceed from here?
So again, we have discussed that after dealing with acute thing, that hypocalcemia we have done with rocaltrol and calcium. Again, that is dose titration method of jovitronic acid is really important, and you can see here that bone density therefore how to go about that. So this dose dependent manner along with clinical manifestation, because this dose is just not dictated by BMD Z score, but the clinical scenario.
So OI, if you have antenatal fracture, you require multi-system treatment. Bisphosphonate is very important, and titrate. Later age, you definitely need to titrate. You don't want to overdo also.
The only problem with the BMD is below 5 years, you don't have a BMD. That's also the reality.
Yes. So largely the titration will happen around that time. You don't expect the BMD to go up so much by that time usually.
Nee, but this is an important thing. Sometimes, I mean, this is a very rare scenario. What you talked about, it is possible if you keep giving the same dose. I mean, on PAMI, I've never, over the last 15 years, never had a problem. But this is something which can happen and one should be aware.
Yeah.
But here, BMD is, or did you talk about it? BMD below 5 years?
One paper from All India Institute of Medical Sciences, which was published in AIIMS, and they have given the data of BMC and BMD for spine for children at 2 years and 3 years, and I think, and they say it is, they have quoted a lot of papers comparing to Caucasian data, and it's very similar. And it is vitamin D independent, and the sample size is very good. So I think that is a positive thing which we can use for our population.
So generally, I won't expect a higher BMD by around 5 years. So beyond the before 5 years, so it should be done typically after that. I think we'll sum up with last two cases.
So we have our next case, this 10-year-old boy who presented with bone pain. He had a fracture after the trivial fall. He also had spinal compression fracture and the BMD Z score of -2.2. So as he presented late, he was diagnosed as idiopathic juvenile osteoporosis. So Dr. Chetan, do you agree with this diagnosis?
On kar. On hai. Ye wala le.
Hello. So this is osteoporosis, no doubt, because of the spinal compression fracture with BMD Z score of -2.2. But still, as discussed earlier, the most common cause of low bone mass and osteoporosis is OI, and milder variety of OI can present at this age. So thorough examination is needed, whether it has got the other features, particularly with the blue sclera, which is the milder variety. So we can examine for blue sclera in patients as well as in family. Many times it happens that one of the parent or family members might have blue sclera with a history of 1 or 2 fractures in whole life as well. So this looks like a blue sclera to me. So this is a milder variety of OI, Osteogenesis Imperfecta.
Now, will you treat?
There is one spinal fracture, so that's an important indication as well. Plus, we have to see the whole history, and this is the guideline. So milder form we might not treat, but we should be keeping check on BMD as well because it has already got a spinal fracture.
So idiopathic term is always which should be done after you excluded everything. Yes,
But
sir.
with a wedge fracture,
You have to treat.
you have
You
to
have to
treat
treat.
because the child is in severe pain. And in fact, these require calcitonin, they require, pamidronate or now zolendronate.
Yeah.
And if they are, pre-pubertal, you might even around the 12, 13 age. Because my first case like this, juvenile osteoporosis, was way back 13 years ago when I just first came. We had to throw everything at the patient. And most important thing is you have to give that to prevent further fractures of the spine. Now this child is 26 years old, no further fractures. And I guess because she's in active ovulation and this and that, the estrogens are keeping her, osteoporosis under check.
So I think IGO is a diagnosis of exclusion, but you may consider, but if there are fractures, you should treat definitely even that.
So moving towards the last case, we have this 15-year-old boy who was a diagnosed case of juvenile chronic arthritis. He was on long-term steroids and he has fragility fractures. When the DEXA was done, he had a BMD Z score of -4.4. He had a testicular volume of 2 ml and the bone age was delayed. It was 12 years.
So he has got all delayed puberty, short stature, everything is there. So Dr. Sugandha, how would you approach this case?
So, as we have learned yesterday, that we should correct the BMD for the pubertal stage.
Yes.
So I would like to know the corrected BMD.
Yeah, so even after that, the BMD was low and he had fractures also. So I think that was something which we were.
This child is on long-term steroids.
Yes.
And along with history of fractures. So these children need high dose calcium supplementation along with vitamin D. According to recent guidelines, 1000 milligram per day should be given along with 600 IU per day of vitamin D should be supplemented. And we can also treat with bisphosphonates.
I think the main message is preventive is calcium and vitamin D. And as soon as you have fractures, you monitor BMD very carefully in these cases and give them bisphosphonate if it's required. So in this case, corrected Z score was -2.8. And in this case, of course, we give zoledronic acid. So again, you have to prevent, that is most important here. But then give calcium and vitamin D, monitor BMD. And as soon as the BMD is falling, remember the first slide I said, if it's less than -3 and on glucocorticoid -2 to -3 with some fracture, then you start treating on that. And bisphosphonate is the key therapy.
But there is no prophylactic role, right?
No prophylactic. Not so if your BMD is less than -3, the recommendations are that if you expect the steroids to continue, better to prevent. So there may be a prophylactic role in a -3 SD setting. It's like growth hormone, how severe you are, that sort of a scenario. So I think this was a wonderful discussion. And I'd like to thank all of you for being part of this session. Dr. Subrato, Dr. Sugandha, Dr. Vijay, Dr. Chetan, and Dr. Vibha.
Thank you.
We will, I think, quickly move to the next session, I think, to
This message, I think we should percolate to the, to our rheumatologists and our hematologists.
Yes.
yes, these are the two ones which use the steroid, one nephrotics,
And
basically.
nephrotics as
These
well.
are the three ones here. Sure. So I
Thank
think this was a very interesting session, and there were a couple of questions which will be there. And now we will move forward to the next and the last session. We are running a bit late, but we'll try to catch some time here and try to finish by 1:15 so that all of you get a good sugar levels. I like to invite, this is the final session. So Dhwani, you can invite the...
For the next session, I would like to invite Dr. Vikrant, Dr. Hemchand, Dr. Rajat, and Dr. Manoj.
So Dr. Rajat has come.
Yes,
Dr. Rajat,
yes.
please come, please come. So Dr. Rajat is the senior pediatric surgeon at Regency Hospital, and he is our go-to guy when we have any of these testicular issues. So we definitely wanted an input from him. Dr. Rajat has done his MCH in pediatric surgery from the prestigious Postgraduate Institute of Medical Sciences in Chandigarh. So what we'll do is that we try to cover off a few important causes, and this is going to be again an interactive session. We will initially touch base about the basics, and then we will have all the cases which will come into the picture. So we will try to cover 4 groups of disorders: hypogonadism, undescended testis, micropenis, and gynecomastia. Hopefully in the next 45 minutes. So I think Alapan will go in sync. We'll have to take Vande Bharat rather than a passenger train probably here. So hypogonadism, just to summarize, we all know that it's the hypothalamic pituitary gonadal axis. You've got the GnRH, which controls the gonadotrophins, which controls the testis. So if you have a problem in the hypothalamus, this is the hypogonadotropic hypogonadism, the LH levels are low. So LH is the best marker as far as the gonadal status is concerned. It is usually constitutional, but if you have other features like anosmia, hearing defect, think of a Kallmann syndrome, and you can have a functional problem. Testicular problem causes a high FSH level, so it's a hypergonadotropic hypogonadism, and that's how you will make a diagnosis. Remember that adrenals produce DHEAS, which is responsible for pubarchy. So if you have got no pubarchy and no gonadarchy, you will basically have a multiple pituitary hormone deficiency, constitutional delay of puberty and growth, or you have a scenario in which you have a problem in terms of the adrenal steroidogenic defect. If you have a normal pubarchy with delayed puberty, it is usually a problem of gonadarchy because of the hypogonadotropic hypogonadism, and that becomes important from that perspective. So hypogonadism can be physiological, which is usually self-limited. These will be shorter children who have got no pubic hair development, who will have a delayed bone age, or pathological, within which you will have hypergonadotropic like Klinefelter, the classical example. Hypogonadotropic may be functional, or they may be permanent because of a multiple or isolated deficiency. We've all discussed in detail earlier on that. So if you have a short child with no pubarchy, think of three conditions: CDGP, functional, multiple pituitary hormone deficiency. If you have normal pubarchy, other conditions become important, and this becomes relevant from that perspective. So if you have a large testis with delayed puberty, this is very unusual. This can be hypothyroidism. If you have a small and soft testis, this is GnRH deficiency. If you have an intermediate testis, this is constitutional delay. And if you have a shorty testis, this is more like a Klinefelter. And of course, if you have no testis, think of anorchia as a possibility in that regards. So if you have pubarchy, if you have stalled puberty, normal growth, and micropenis, it is not CDGP. You're dealing with something else. And biochemically, if your inhibin B is low, GnRH stimulated LH is low, it is unlikely to be CDGP. So the first evaluation is to do gonadotrophin levels after the screening test. If they are high, do testosterone. If they are low, do a karyotype. If you have a high testo, then you have rare possibilities of 5-alpha reductase versus AIS. They will usually have hypospadia, so they will present with DSD usually. If you have low gonadotrophins and pointers of hypogonadotropic hypogonadism like micropenis, undescended testis, then you can think of a permanent HH. If not, and your testicular volume is low, inhibin B is low, this is permanent HH. While if testicular volume is more, inhibin B is more than 100, this is CDGP. And in between, you look at inhibin B. So basically, you're looking at LH, FSH, inhibin B, and testicular volume. This will give you the diagnosis in most cases in that regards. Treatment, basically, you use testosterone enanthate, which is an intramuscular injection. And usually we start with low dose and build up by around adult dose of 300 milligrams per week. And you can also have 1,000 milligram injection, which is to be given after the pubertal induction is done every 3 monthly. We don't usually use the gel or the oral preparations much. For CDGP, start with a low dose of 100 milligram monthly for 3 to 6 months and look for reversal. For permanent, you use again at 12 years and gradually build up the dose over 2 to 3 years. There is an option for fertility in hypogonadotropic hypogonadism. You can achieve fertility using LH and FSH. For hyper, it's only donor insemination. The chances are very, very minimal. So we'll start with the cases now, Dr. Alapan.
Thank you, sir. Our first case, a 14-year-old boy presented with delayed puberty. He has a similar history in his father. His height was on the shorter side. During his regarding his puberty, his testicle was prepubertal, volume of 3 ml, and a pubic hair of stage 1. So, Dr. Vikrant, sir, I would like to ask, how would you approach this case?
Well, as sir has already told, we have got a good family history that is present, and the child is short and who is having a testicular volume that is more than 1 ml, and pubic hair staging is 1 prepubertal. So it looks more like a constitutional sort of thing. So if we go by the algorithm, it looks like a constitutional delay of growth and puberty.
Yes, and this child had no pointers of hypogonadotropic hypogonadism, and inhibin level was on the higher side, 125.
That is the most important marker. Even before testosterone serum inhibin starts rising. So this is a pretty much pointer towards the fact that we are dealing with something constitutional.
So I think this is very, very nicely put in that this is like a classical picture. So how will you now treat this case, Dr. Vikrant?
If the child is, since the child is more than 12 years, bone age of more than 12 years, we can give a push with testosterone 50 to 100 milligrams per monthly for 3 doses, and then we can look for the puberty to happen on its own. And most likely it will happen on its own once the push has been given.
Yes. So this is clearly no pubarchy, short child, testicular volume is high, high inhibin, give a course of androgens, and you are starting the engine, basically, you're pushing the engine.
Again, our case 2, a 15-year-old boy with delayed puberty, but this time the boy had a small phallic size at birth. Height is in the normal range in the 162 centimeter. But this time, in contrast to the previous one, this testis was 1 centimeter with a soft testis and a pubic hair of stage 3. So, Dr. Hemchand, sir, how would you like to approach this one?
Thank you. I think this case represents a total contrast to the previous case. If you see the case presented by Dr. Vikrant, he had a normal phallic size and the testicular volumes were 3 ml. But my patient, the phallic size is small at birth and the testicular volumes are just 1 ml. I have a petrol tank that is empty. He had a petrol tank that was in the reserve stage. I think that is the understanding. His is in the reserve stage, my tank is empty. And the second valuable clue is the dyssynchrony. In his case, the testicular volume and the pubic hair, both of them were dormant. But in my case, the pubic hair is behaving normally, but the testicular volume is dyssynergetically in a very quiescent stage. I think this is a classical case of hypogonadism. In the writing is in the wall on a clinical assessment.
Yes, sir. Again, there was no pointer suggestive of hypogonadotropic hypogonadism, but inhibin level was less this time, 20 picogram per ml. So
I think as per the algorithm, you have beautifully said, this child is moving himself towards a case of hypogonadotropic hypogonadism.
So how would you manage from here, Dr. Hemchand?
See, I think the management of this case should be, it's the story of the rabbit and the tortoise. He has managed, Dr. Vikrant has managed it like a rabbit. He has given a stiff dose of androgens and he has stopped it. But I am like a tortoise. I have to go slow and steady because I have to mimic nature. I am dealing with a child with a disease. So I have to water the plant very gently. So I'll start on the lowest possible dose, which is 25 to 50 milligram IM, slowly increase by 25 to 50 milligram IM, and I will try to mimic what nature would have done. I would try to go slowly like a tortoise and mimic what nature would have done, slowly increase the size, slowly advance the secondary sexual characteristics, slowly improve the bone mineral density, and slowly advance the growth. But unfortunately, one thing which I am not able to do by this is push the testicular volumes upward. That is something which I cannot do by giving testosterone. So I would probably have to give them some amount of HCG at the time of fertility or as per the clinical protocol.
So we followed up this patient at 26 years regarding concern about the fertility. The testicular volume was again the 1 ml range, but this time we started HCG of 2000 international unit and FSH of 150 international unit.
So I think the fertility options would be there as discussed. So LH and FSH will be the one to go forward. Yeah.
And we started after starting, there was an increase in the testicular volume as well as the couple had conceived within the 12 months of age.
So this is a very important message that even the very bad cases of Kallmann syndrome, if you treat them well, they will be able to achieve fertility, but it will take 6 to 12 months of HCG and HMG. A big message here is that if it is a congenital form, always give FSH along with LH. Because if you do not give FSH, your HCG will increase intratesticular testosterone and it will destroy the germ cells because there is no protective Sertoli cells. So always combine both LH and FSH in that perspective. So this was a permanent HH. I think Dr. Hemchand clearly said if their prebubarki was there, inhibin B, and they have a fertility prospect.
Now the case 3, a 16-year-old boy with a pubertal concern. He had a pubertal onset at around 13 years, but the pubertal...
Yeah, Dr. Ahila, you wanted to say something? Recombinant FSH, there is very expensive and there is no benefit. Studies have shown so HMG is pretty good enough because FSH, LH, the recombinant ones are very, very expensive.
But the puberty has stopped for 2 years. Now he had a testicular volume of 3 ml soft and a pubic hair of stage 3. His height was a normal range and he was diagnosed as CDGP. So Dr. Manoj sir, do you think the diagnosis is correct?
Thank you, Alappan, for the case. So we have discussed the previous 2 cases. We have seen in one case where it was a CDGP, where growth is delayed. And the second one that Dr. Hemchand has discussed, it was about the HH. So now this is the case of the stalled puberty. If we see the previously testicular volume was there, pubic hair was there, and after that something has happened that was not going towards the puberty. So it is a stalled puberty. Suppose one child is growing and it stopped growing, then something pathology is going on. So in this case, in the case of the stalled puberty, CDGP is not a diagnosis. We have to think about something pathology, like some tumor is sitting there or some Klinefelter syndrome is there. So we have to think in this perspective.
So this was very important. The LHFSH was low and we found a large cranio sitting in there. So delayed puberty is not just about puberty. It can be a manifestation of a serious underlying disease if it's an acquired cause. Always be very, very worried if it's an acquired cause. Get an MRI done definitely. So organic pathology, again, as you said, neuroimaging is mandatory and normal height is against that.
Our case 4, a 15-year-old boy presented with delayed puberty. His testicular volume was 1 ml with no anosmia. The gonadotropin levels were in the lower side with normal screening test and MRI. We have given injection testosterone 100 milligram per month. So
on follow-up, what we found was that his testicular volume increased on follow-up. So is this different, Dr. Vikrant, now?
Yeah, obviously this case is different from the past because normally testosterone is not expected to increase the testicular volume. It can only increase the level of testosterone. So if this is increasing on its own after giving testosterone therapy, it is a strong pointer that we will be dealing with some reversible form of hypogonadotropic hypogonadism. As we have seen, hypogonadotropic hypogonadism is oligogenic in nature. It has a lot of redundancy, just 10 to 15% of the neurons are working, then still the pregnancy can progress. Still the puberty can progress. So this is a reversible form. So basically CDGP and hypogonadotropic hypogonadism are not different entities. They are just the two ends of a spectrum. Say if 30-40 are working, then after giving a push, they have to later on also they may falter. So
I think that's a very, very important point. So different from Dr. Hemchand's case in which the TV remained low. It was like a permanent Kallmann, nothing is there. Here you have a chance of reversibility. Yes. So if your testicular volume increases, this is reversibility.
our case 5, a 17-year-old boy presented with pubertal concern. Again, his puberty started around 12 years of age, but stopped for 3 years. But in contrast to the third case, the testis was 2 ml, farm 1. He had gynecomastia with a taller height of 182 centimeter.
And he had pubic hair as well. Yeah.
Yeah, so I think the writing is on the wall. This is a pathological cause. What are the red flag signs we can see? Presence of gynecomastia, presence of a small shorty testis, a firm testis, as I mentioned previously, tall stature. I think these are good enough clinical pointers to tell that we are dealing with an underlying syndromic condition for delayed puberty. So I think this puts that this child has a pathological cause. And if you see as per this algorithm, you really know that this child needs to be screened using gonadotropin levels and the testosterone levels. So the gonadotrophins are like choke of a bike. The higher the gonadotropin levels are and lower the testosterone levels are, it means that the gonads are moving more towards failure. So this is a gonadal failure response, and the cause of gonadal failure response has to be ascertained. So a karyotype analysis is done and a diagnosis is arrived at.
Dr. Rajat sir, I want to ask whether any surgical opinion regarding this gynecomastia.
Because they are very concerned with gynecomastia actually.
Adult patients who are above 15 years of age can be offered surgeries for gynecomastia, but the surgical treatment should be offered only after a diagnosis has been made and only after the medical treatment has been at least initiated or completed. So
I think that's a very, very important point, because often when we start with testosterone, the gynecomastia may worsen initially because of aromatization,
Right.
but after 2-3 years, it comes down. So this is something which is there. Yeah. So I think that's a very, very important point from that perspective. So tall stature, stalled puberty, shorty testis, this is Klinefelter syndrome. Gynecomastia is a common one. They don't have chances of fertility, are very, very poor.
Our next case, a 18-year-old boy presented with delayed puberty. He had a surgery for penoscrotal hypospadias with a penile length of 3.2 centimeter and pubic hair of stage 4. He had inguinal testis and gynecomastia, and his LH and FSH level was high. So Dr. Manoj sir, what is your next plan?
So here 18-year-old boy was there and the delayed puberty. Here penoscrotal hypospadias is there with the micropenis, and pubic hair is normal, and with the higher level of the gonadotropin, and the test, if we see the testosterone level is very, very high. So we can assume that until there is no any issues, after that some problem is going on. So we have to do dihydrotestosterone And can you elaborate what is the ratio? I think it is a high.
Yes, sir.
So
It was
basically,
high
you've got a
ratio,
high
better than
testo and a
10.
low DST.
Low DST. So that it is a like Srikhandi syndrome that we have discussed yesterday. That some problem is going on from conversion of testosterone to DST. So this is the case of the 5-alpha reductase deficiency.
This was okay. So it was more like a partial AIS. Testo was high and
DST was
DST was also high. So
Okay.
this was actually partial AIS. So there was some miscommunication. So this was actually a partial AIS. The message is if you have delayed puberty with hypospadia, it's going beyond. So it can be 5-alpha definitely. And both of them you have to consider partial AIS versus 5-alpha reductase. Both are similar sort of a presentations, I would say. So what would be the recommendation about the penile size? Because they were very, very worried. Now, how effective are penile lengthening techniques, Dr. Rajat?
Most of the hypospadias cases respond well to stage surgeries. Penile lengthening, if there's a associated chordy that is with hypospadias where there's a bending of the penile tissue, so chordy correction does improve the penile length, but surgically there are not many procedures available to increase the penile length.
I think that's a big message that they were going to different surgeons and they were trying that it will increase the size. And then we said, no, it's not going to help out in that regard.
So most of the hypospadias cases, the endpoint of the surgery is that the child should be able to stand and void properly. He should not wet his clothes or shoes. And the penile size, it should be a little above micropenis.
Yes.
There's not a set criteria that how much
Yes.
should be the penile
And
size.
partial AIS, usually if you give high dose testosterone, you may see some improvement. So it's going, this is a very challenging case. I think he was supposed to come in that case as well, but it's a difficult case, I would say. It's not as easy as, let's say, Kallmann is the easiest. Then you say Klinefelter, you can't achieve fertility. Here, both sexuality and fertility will be compromised. So we'll quickly go through to undescended testis, which is very common. 1 in 40 children will have cryptorchidism at birth. 70% will descend. 30% of these will remain permanent. More common in preterm babies. And usually you will see a temporal trend. The testicular descent will usually happen within the first 1 year. So if you do not have a descent by 1 year, it is usually permanent. Often beyond 4 months, the weight is not going to be much helpful. So sometimes between 4 months to 1 year, best to go ahead with a pediatric surgeon. Other messages, HCG is not recommended as a therapy. As I said, it can damage the germ cell. So do not give medical treatment unless you're thinking of hypogonadotropic hypogonadism, which is very rare to diagnose at that age. And then you give it along with HMG. That is a big message from there. So this is the manifestations from that regards. So the criteria basically are 4 months of age, no scrotal testis, look for scrotal growth, look for, sometimes the testis may be there. So you ask them to go into a tailor position, squatting position, cuff reflex, warm hand, palpate right from a 2-hand technique, starting from the superficial inguinal ring to scrotal sac and try to bring down the testis. And you will be able to identify, because unnecessary referral should also not be done. And often Dr. Rajat will say that, okay, you will get a case is referred as undescended testis, and he will palpate and tell that nothing is required in that regards. So the approach is to exclude common causes. If you have palpable gonad with hypospadia, that's a different ball game. That's a DSD. You evaluate for that. We discussed. Dr. Manoj presented a wonderful one. If you have a palpable gonad, which is up there, but there is no hypospadia, send for surgery. Don't wait beyond 4 months, 12 months, definitely not. If you have no palpable gonad, now, if it is unilateral, of course, you have to do an exploration. That becomes very, very important. If it's bilateral, and you have a Mullerian structure, it becomes again XX-DSD. So you have to evaluate. If it's absent, look at AMH and see whether it is anorchia versus abdominal testis. If you have abdominal testis, you explore. So look basically at the Mullerian structure, hypospadia, then AMH, and you will get the right diagnosis in that perspective. So you should refer any neonate with bilateral non-palpable testis, immediate evaluation, exclude XX-DSD. You may miss the child because this may be CH. Bilateral non-palpable testis at a later presentation, if the AMH is detectable, sent to the surgeon for abdominal exploration. Unilateral palpable / non-palpable testis after 4 months to 1 year for orchidopexy or laparoscopic evaluation. And if it's acquired also, send immediately. Sometimes you have an acquired ascent which may happen. If it's a palpable atrophic testis, you have to remove. I think that will be an important part to look at.
So our next case, a neonatal case of neonate presented with bilateral cryptorchidism, had a normal penile size. He was reassured. So Dr. Vikrant sir, do you think it was done right?
This is the most common thing that we should be wary of. If the scrotal sacs are empty, so we may be dealing with some form of XX DSD like congenital adrenal hyperplasia, and that can be fatal if that is left on its own. So always we have to check for the Mullerian structures, whether they are present or not. If present, we should go for the 17 OHP levels. If more, then of course the diagnosis is CAH, and then it has to be treated accordingly with the cortisol and all those things.
So non-palpable gonad is a medical emergency. Do not avoid that.
Again, an 8-year-old boy, a obese boy with a left undescended testis. Dr. Rajat sir, what is your advice regarding this?
So the image, I would say it's more or less normal. Someone would say that it looks like a micropenis, but for a healthy 8-year-old boy with a lot of fatty tissue in the pubic area, I think the stretch penile length would be easily more than 3 centimeters.
Yes. And somebody said that the testis is not palpable, so, which often happens in obese children. Actually.
So that can happen. Sometimes there's a retractile testis, or the parents may have not noticed this for many years. So we start with a simple clinical examination. Mostly in 90% of the cases, I would say the testis would be palpable somewhere in the inguinal canal. And then we follow up with the ultrasound lower abdomen, which would localize the testis near superficial ring or deep ring, and then we can proceed with the required surgery.
I think very important, before we really label and refer through a surgical intervention, we should be very careful clinically. Right. That's a big message in that regard.
Next case, the 6-year-old boy presented again with a left undescended testis. He was undergone for orchidopexy, but his scrotal sac was well formed. So Manoj sir, what do you think about this case?
So here we have a 6-year-old boy who have an undescended testis, and the scrotal sac is very, very well preserved. So here Dr. Anurag sir has said that we do have a do proper examination, that it is a retractile testis or it is a true undescended testis. So suppose if we have a retractile testis, then if we do properly manipulation, then it can come into the scrotal sac. In that particular case, we don't have to go for the surgery. So this is the message, that before any conclusion, we have proper examination is must.
So if you bring down the testis to the scrotal sac, keep there for a minute, it will then remain there. That is the message there. Now, in this case, of course, retention test will give you a clue. Dr. Rajat, some people talk about doing a stitch or something so that it doesn't ascend. What is your opinion on retractile testis?
So mostly, I don't recommend a surgery for retractile testis. But mostly what we tell the parents is observe the child while he is sleeping. So if during sleeping you see that the testis is in the scrotum, then mostly we say that it doesn't need a surgery. And if the parents say that even while the child is sleeping, but most of the time they don't see the testis in the scrotum, and it is always suprascrotal.
Yeah.
And even if during a clinical examination the testis stays in the scrotum after stretching, keeping it there for a minute, but most of the normal hours of the day the testis is suprascrotal, yes, then sometimes you can offer a surgery.
Yeah.
But I don't think there's a very documentary evidence supporting the surgery, but sure, it can be done.
Sure. So
our next case, a 13-month-old boy with bilateral cryptorchidism. Dr. Hemchand sir, what would be your approach in this case?
I think this is definitely a child who has bilateral cryptorchidism is a red flag sign. So definitely we have to see whether we are looking at a 46XX DST, bilateral anarchia, or intra-abdominal testis. So I think, as you have beautifully put it below, an ultrasound should be done, an AMH should be measured, and see which direction this child is going to.
So now this child had no Mullerian structure, so DSD was ruled out. AMH was high, which means gonads are somewhere. So now what do we do, Dr. Rajat, in this case?
For any child with the bilateral non-palpable testis, is the first procedure. You can go with simple ultrasound lower abdomen. If the testis is near the deep ring, mostly ultrasound will pick up a testis. If it is near the deep ring or near the urinary bladder, I think for any patient unilateral or even bilateral undescended non-palpable testis, the first thing that should be watched for is the pigmentation and texture of the scrotal skin. If the scrotal skin is pigmented and there are significant rugosities, then you can be nearly 100% sure the testis is somewhere in the abdomen. So if the second step is to do a MRI to specifically localize the testis, and for a bilateral non-palpable undescended testis, we go ahead with laparoscopic surgeries and follow up with a
I think this is very important because you want to remove them basically, otherwise, or try to bring them down if possible.
For a 10-year-old child, I think directly removing the testis, even if the child is 10 years of age, has some sociological issues also. So mostly we said that we'll try to bring them down. Once the testis is brought down, at least the child can do a self-examination. And if in future some pathology develops, then we can do orchidectomy later also.
So AMH is the best marker of testicular tissue. Need for urgent evaluation.
Move on to the next case. A 14-year-old boy with right undescended testis. He had undergone orchidopexy 4 years ago. Now he has presented with testicular swelling with loss of testicular sensation. Dr. Vikrant sir, what is your opinion regarding this case?
Now, this is the red herring. Even after bringing the testis down, after performing a orchidopexy, the chances of getting it into malignancy, turning it malignant, that still remains. So, and the loss of testicular sensation alludes to the fact that we may be developing some tumor or intratesticular sort of malignancy.
So, Dr. Rajat, how would you approach this case? Like,
for unilateral testis with the suspicion of any malignancy, first we go ahead with endocrine evaluation, beta HCG, alpha fetoprotein. And if there's any direct or indirect sign indicating that there may be a possibility of any malignancy, we go to high inguinal orchidectomy.
And is there any role of FNAC in this setting?
Mostly, we don't.
I think
go
that's
for
very
FNAC.
important that FNAC should not be done in this case because it may cause more problems because testicular tissue may be exposed, autoimmunity, everything will happen in that scenario. So testicular descent does not prevent the development of a tumor. Loss of sensation is the first sign. So self-examination is very, very important.
Our next case, a 14-year-old boy with a left undescended testis. This time the right testis was 8 ml, but the left one was small, 1 ml around. Dr. Rajat sir, I would like to ask your opinion regarding this.
So now for a 14-year-old boy with the very less volume left testis, I think the best surgical treatment that I would offer is that we would like to do orchidectomy on the left side and place a prosthesis.
Yes.
There are silicone prosthesis now available in various sizes. So mostly we wait till the patient has achieved puberty. So 14 years, maybe we can do it at the same time or maybe 2-3 years later.
Yes.
But that should be the best option, I think.
So the guidelines are now shifting towards probably what Dr. Rajat is saying exactly is that there's no point. This is like a time bomb there unnecessary. It's not doing anything. It's an atrophic testis, best to remove. Like for abdominal gonads in a Y cell line in Turner's, we say remove the gonad. Something like that. It has a reasonable risk of malignancy, so orchidectomy should be gone. So unilateral orchidism, there is no role of medical treatment. Avoid HCG. This is one big message you like to give. Surgical removal if it's late and atrophic. We'll quickly go to micropenis, which basically means that you have a normal male with the size below -2.5 standard deviation score with a normal genital appearance. So a normal median raphe, normal foreskin, and a urethral opening. Now, we all know that the major growth of penis happens within the antenatal period, and between 8 to 12 weeks is very crucial because that's the time the fusion happens. So problems before 12 weeks, which is testosterone synthetic defects or action defect, will cause hypospadias. Beyond 12 weeks, which is classically hypogonadotropic hypogonadism, you will have micropenis with normal genital appearance. After birth, you will gain around 1 to 1.2 centimeters in the first 1 year. and subsequently there is no growth till puberty. So if somebody has a small phallic size after 1 year, no point keeping on in that regard. If it's an early presentation, maybe wait and watch for some time. Otherwise, giving a course of therapy will have an important role, because the increase in penile length is fixed. So if you are having short penile length at the onset of puberty, you will have a shorter towards the end of it as well. So definitely, if you have hypospadia, you are worried. And if you have micropenis, of course, you will see if it's at an early stage, you will wait and watch till 1 year, give treatment otherwise, and then go from there. There are now references available, so we'll not go much into details as to what criteria. So if it's less than 1.9 centimeters at birth, 3.1 at 1 year. Dr. Vaman has come up with the study, and Dr. Vijay was part of that study as well, which looked into that data from that perspective. So if a child is more than 5 years, less than 4 centimeters, this is what you need to be worried about from that regards.
So move on to our next case, a 8-year-old boy with a small phallic size. So Dr. Manoj sir, what would be your advice to
So yeah, if we appreciate in this picture, then it is a really case of the micropenis. So 8-year boy was there, and it was an obese child. So this is not a case of the DSD, but it is a case of the micropenis. So here proper examination is must, that either we are dealing with the micropenis or buried penis. So for the proper steps, what we have to do, we have to measure at the dorsal surface. It should be stretched penile length, and pubic ramus should be placed, and so we can exclude the excess fat, and excess skin should be removed. And after that, if it is in criteria of the micropenis, then we have to treat in this case. If it is not in micropenis, then it is because of the obesity, or it is because of the buried penis.
So this is the most common presentation of buried penis. So don't unnecessarily work up in that regards.
Our next case, a 3-day-old boy presented with a micropenis stretched penile length of 1.8 centimeter with a testicular volume of 2 ml, and he was discharged and again presented with seizures-like manifestation. So Dr. Vikrant sir, I would like to ask you about the opinion regarding this case.
Micropenis, any midline defect, they may be pointed out towards something that is related to pituitary, some multiple pituitary hormone deficiency sort of situation can be, the child may be inhabiting that. So the patient was discharged. So it was not a good decision to discharge the patient before getting him worked up properly. So as you have nicely put it down, the sodium is pretty much less, so it may be hyponatremia because of some cortisol deficiency.
So he had hyponatremia, hypoglycemia, so this looked like a multiple pituitary hormone deficiency.
And that would be fatal if not properly treated.
So anybody with micropenis, this is again a medical emergency, especially in the neonatal period. You do urgent glucose and that.
Our next case, 3-month-old boy presented with micropenis and hernia. Electrolyte levels were done, which was sodium was mildly decreased to 130 millimole per liter. Potassium was slightly raised, 5.8 millimole per liter. He has a microcephaly of head circumference around 32 centimeter and a prominent facial features like upturned ears, lucid ears, and also he had micropenis-like situation. So Dr. Hemchand sir, what would be your opinion?
I think you have given the diagnosis, as you may elicit the history, the presence of head circumference that is below 2 standard deviations. You have a prominent upturned ears, and you have micropenis, and you have dyselectrolytemia. All this is pointing towards an underlying genetic condition, which is quite known to be associated with cortisol synthetic defects. So low cholesterol, low cortisol, microcephaly, limb anomalies, all this points out to a genetic disorder, Smith-Lemli-Opitz syndrome. I think this has to be kept in mind in this condition.
So very careful clinical evaluation becomes very, very important.
Again, a 3-month-old boy with a small phallic size. SPL was 1.6 centimeter. Testis was bilaterally palpable or 2 ml. LH-FSH level was on the lower side. So, sir, what is your plan, Dr. Manoj sir?
So this is the case of the 3-month-old boy who came with the stretched penile length of 1.6 centimeter. So here we have to and LH-FSH at this age, the boy should be in the mini puberty. If LH-FSH is really low at this stage, then either we are dealing with the multiple pituitary deficiency, or either we are dealing with the hypogonadotropic hypogonadism. So we need to work up for that. And we need to give testosterone if its size is not improved after that.
So we followed up, there was no increase in the penile size and testosterone was given in the 3 cycle 25 milligram. Again in the 14 years, the boy presented with anosmia and delayed puberty.
Yeah, so now really the pointer has came. Like previously the picture of the child was not in puberty, mini puberty, and the micropenis was there. Now the anosmia was there. So now it is clearly pointing towards that we are dealing with the hypogonadotropic hypogonadism. So we have to induce the puberty, as Dr. Hemchand has said.
So very importantly, most patients with isolated micropenis will improve after a course of testosterone, but always call them back at 12 to 14 years. There will be 10-15% who may have hypogonadotropic hypogonadism who will require support subsequently. So this is something which is very, very important. Yes. Yeah, we discussed that in the initial cases about the TV and that level. Now we'll go quickly over to the last part of our discussion on gynecomastia, which is also a very common presentation in adolescents. So gynecomastia usually is physiological, which could be neonatal or it could be pubertal. Pathological causes could be either because of androgen deficiency, estrogen excess, or systemic causes. Now, when you have hypogonadotropic hypogonadism, gynecomastia is milder. Klinefelter hypergonadotropic hypogonadism or partial AIS or 5-alpha, partial AIS, you will have much bigger gynecomastia, which is there. Testicular tumor are rare, but you need to be aware about that. You can have HCG and adrenal tumors as well. And importantly, hyperprolactinemia does not cause gynecomastia directly. It causes gynecomastia through hypogonadism. So if you have a borderline prolactin, don't get too worried about that in that regards. So when you say gynecomastia, it's a benign symmetrical development and it's a fibrous concentric tissue. Always exclude lipomastia. So palpate the breast tissue using a thumb and finger, approximate if it's coming closer without resistance. This is basically a lipomastia. Otherwise, it's a gynecomastia. So this is usually a bilateral process. Tenderness again is common in this age group, which will improve. So if you have an onset during puberty, with pubertal stage 3 and 4, testicular volume 8 to 10, diameter is not too much. This is physiological. If it's before pubertal onset, after pubertal onset, if it's much bigger, diameter is much more, think of a possibility of a pathological cause, which will be, you have to worry about in that setting. So when you want to evaluate, you see whether it's really requiring evaluation pre or post pubertal onset and a big size. In that case, if it's not there, no evaluation. If it's there, look for common causes like drugs, liver, thyroid, renal disease. If there is there, you manage them. Otherwise, you do a testosterone. If it's low, it could be hypo or hypergonadotropic hypogonadism. If testosterone is high and your LH is high, this is partial AIS, or low, it could be a testicular tumor. And if testosterone is normal, then you look at HCG tumor, which is rare. So most cases, you may need no evaluation. In certain cases, you will need testosterone and LH. Rarely HCG will be required in this scenario.
So next case of 15-year-old boy presented with gynecomastia. It was noted 1 year ago. It was a non-tender swelling with the testicular volume was around 4 ml. So Dr. Rajat sir.
So this is a common presentation that we get during puberty.
So mostly during puberty, some mild gynecomastia testicular volume is less than normal. So I don't think any intervention is needed in this.
So
patient.
this is most likely a lipomastia, first of all. And then even if it's gynecomastia, this will be physiological. So you palpate the tissue and no workup is required here.
Move on to the next case. A 14-year-old boy presented with gynecomastia. It was noted 6 months ago. It was a tender swelling. The testicular volume is around 4 ml. Dr. Hemchand sir, I would like to ask you about this case.
I think this is a child with gynecomastia, probably pubertal, but it is symptomatic. So I think this symptomatic child, I think the onus is on us to provide relief for this child. So I think a testicular volume of 4 ml suggests that this child is having the onset of puberty and 14 years is the age and he's symptomatic. So there is a mild increase in the estrogen levels, which is probably responsible for this. So a trial of pharmacotherapy can be considered after explaining the pros and cons to the disease.
Or you can do local measures. So it's up to the physician, I think, what they're comfortable. So reassurance may also be a good one. So physiological gynecomastia is when you have near the puberty.
Next case, 18-year-old boy presented with gynecomastia. It was noted 3 years ago. It was a non-tender gynecomastia. Testicular volume is around 20 ml. Dr. Vikrant sir, what would be the approach in this case?
Now this is a red flag. 3 years ago it started and now still it is persisting after 18 years of age, and that too with the testicular volume of 20 ml. So I should be a bit wary about it. I will try to probe it further. What needs to be done.
So we need to evaluate for the cause and
For the
candidate
cause
for
and-
the definitive treatment in this regard. So if you have a pre or post pubertal onset, large size persistent, this is a bad sign. You need to evaluate.
Our next case, 17-year-old boy with breast enlargement. It was a recent onset and a rapid onset. Testosterone level was sky high, 920 nanogram per ml. So Dr. Manoj sir, how would you like to go ahead with this case?
So here, a child, I think they, has a 17-year-old boy and who has a breast development which was a rapid. So here it was if something is going very, very rapidly, then we have to be worried. And testosterone level is very, very high here. And LH is low. So can you, yeah. And there was a testicular lump and the Leydig cell tumor. So LH is suppressed and there is a high production of the testosterone. So here we have to think about the tumor. Either there is a testotoxicosis or subtumor is sitting there.
So mostly you will be here, no evaluation required. We discuss cases where you may have just lipomastia. Otherwise, you will have to consider testosterone low, then Klinefelter. Otherwise, this is the tumor. Leydig cell tumor will be there. Rapid progression, virilization, high testo, low LH. Dr. Rajat, what is the management of these tumors?
For all testicular tumors, the first surgery after proving the diagnosis is high inguinal orchidectomy. After high inguinal orchidectomy, the patient is advised to continue with self-examination of the opposite testis, because there have been cases where the patient who has had a testicular tumor in one side may have a tumor on the opposite side also. Biopsy we don't do.
Yes, yeah. So I think that's very, very relevant talk, that you just have to look at the other side also, whether you have a bilateral, because you may have a predisposition syndrome which may cause that. So I think that brings us to the end of this marathon event that we have been conducting for the last 5 days now for many of us. And we'll see if there are any questions which are there. Obese children coming with significant gynecomastia, do you evaluate or treat? Depends upon whether it is physiological or pathological. That will be the major factor to look at. Dr. Mohammed is asking whether you will have recordings. Yes, we will, after getting clarification from the and the permission from the speakers. So I think I'd like to thank all of you for this great session. Dr. Vikrant, Dr. Hemchand, Dr. Manoj, and Dr. Rajat. I'll request Dr. Vibha to give a token of appreciation to Dr. Rajat. We have already felicitated the others as well in the previous ones. Please come here, Dr. Rajat. Thanks a lot. So before we break for lunch, I like to thank everybody who is here in the hall, who was here for such a long time and made this successful. All the faculty who has come from far off places, Dr. Ahila, Dr. Subrata, Dr. Hemchand, Dr. Vikrant, Dr. Vijay Jaiswal, Dr. Chetan, Dr. Riddhi, Dr. Sugandha, and Dr. Manoj, everybody, all the other members who have been there, the team members who are there, I'd like to thank all of them. And I'd like to specially thank 3 of our fellows who have done a very, very hard work. And I'll request Dr. Subrato to kindly come up and Dr. Hemchand to come up and give them tokens of appreciation, please. So all 3 of them had spent a lot of sleepless nights for so many days, and the other ones. So I'll first invite Dr. Vibha. So Dr. Vibha is now in the 2nd year and she is a very hardworking. I'll invite Dr. Dhwani. So Dr. Dhwani had anchored the program very nicely. And Dr. Alapan and Dr. Hemchand had a good interaction with Alapan even before the conference. I'll also thank the entire Grow India team. We have got Hariom, Nikhil. Please come up. We'll have a group photograph. So, and Aditya and all of them, Prashant ji, for being part of it. And maybe all of you can also come up. So for making this event successful. And we have got many other people who have been involved in this program. Ravidat Bhaiya, please come up. Rishi ji and Umesh ji, they have been central to this program. And so we'll thank all of you, and we want to give them a big round of applause because they have made it possible on that. Thanks all of you for this wonderful program, and we'll close the session and we'll try to make the findings available as well.